Let's now just talk about acute GI bleed, and most common presentation is hematemesis followed by melena. Urea might be elevated because of protein-rich meal, which the blood itself is. Some of the interesting things or unusual presentations include diol phase lesion, wherein there are no prodromal features prior to hematemesis or melena. It's due to an AV malformation. Therefore, there's a considerable hemorrhage, and it might be difficult to pick up on endoscopies. Endoscopy might be normal previously. Other than that, mainly, how do we manage it? So we have two scores. First is Glasgow-Blatchford score, which is used to decide whether the patient needs admission. It uses urea, systemic blood pressure, hemoglobin, and other features such as pulse or syncope, heart disease, cardiac failure. Then there is Rockall score, which is used after endoscopy to predict what's the likelihood of rebleeding. Mainly, obviously, the treatment is ABC, fluid resuscitation, platelet transfusion if active bleeding with a platelet of less than 50, or FFP, or if the fibrinogen levels are low, or if the INR is more than 1.5 times the upper limit of normal. PCC, prothrombin complex concentrate, in patients who take warfarin and are actively bleeding. So PCC for warfarin, FFP for INR or APTT more than 1.5 times the upper limit of normal. Then treatment escalation is to give PPIs for varicose bleeding, but it's the other way around. So NICE does not recommend the use of PPIs before endoscopy to patients suspected of varicose bleeding, but for non-varicose we need to give PPIs. If there's further bleeding, then repeat endoscopy, interventional radiology, and even surgery. For varicose bleeding, the treatment includes terlipressin, prophylactic antibiotics before we do the endoscopy. For esophageal varices, we use band ligation, and for gastric varices, we use the cyanoacrylate injections. If all of this fails, and if it's a varicose bleed, then we can offer TIPS procedure, which is transjugular intrahepatic portosystemic shunt.